We are at week 7. We have one chapter that we're covering from our mini session. I grabbed a little bit of the tidbits that are important and sprinkled them around. We have 2 questions that we're going to answer right after our quote of the week. We have a group discussion that we're going to set up this evening, and then we're going to bring it back next Tuesday, and it'll be explained once we get there. And then we're going to wrap it up, take a break, and then come back for those of you who can for our makeup session of ST200 afterwards. Okay. But I did just put in the link just in case those of you who had not had the opportunity to watch that mini session on chapter 16. Now, for our quote of the week, your present circumstances do not determine where you can go. They're merely determining where you start. Now, this quote, if you think about it, is actually very inspiring. It reminds us that no matter where we begin, our circumstances do not define our future. The journey ahead depends on the actions that we take and the determination we have to move forward. For us as surgical tax, this is a very powerful message emphasizing that regardless of current challenges, each step of growth, each module you pass, each midterm and instrument that you give to your surgeon is an opportunity to grow in our field. So keep pushing forward with each lesson and skill that you will gain. All right, now a little bit of some imagery this time. So in the mini session, there were a lot of images that were put up, okay? Now you're looking at these photos, and by typing in A, B, or C, just guessing if you hadn't had the opportunity, which one is an image of Brucellocay from the mini session? Is it A? Is it B? Or C? And I see someone got it correct already. Um, just in case anyone has, okay, yes. I don't know if they saw yours, Kevin, but yes, good job. It is B, Brucellocay. Not even saying if I'm sure if I'm saying it correctly, but one thing about this one is that it infects the body through breaks in the skin, your mucous membranes, ingestion, and unpasteurized milk, or even inhaling aerosols. Now, A is protobacteria. It's a large group of gram-negative bacteria. And C is this one right here, is the genus Kingula. Okay. It's part of the beta probacteria class, and it's the Neisseria family. It includes different species of Kingula kingae. Okay. But yes, B is Brucellocay. So good job, everybody. We're not done yet. I like to do by twos. Okay. So true or false? Provincia strudite is commonly found in animals such as cats, dogs, birds, sheep, and reptiles, where it typically causes severe infections in humans. Keyword that we're looking at, severe infections in humans. Is this false? See why it's so somewhere. In my urinary tract, gastroenteritis. Um, you guys didn't hear me? Okay. Because I saw that my internet was going a little bit crazy. All right. So I will type in. You guys still can't hear me? Can you hear me now? I see. Okay. Okay. So what made this answer incorrect was this part right here. So causes severe infections in humans. It usually lives harmlessly in these hosts. Okay. That's what made it incorrect. So it's kind of like, going through, and then you pick out, wait a minute, it's already on the host. Usually it's not bothering us. Okay. So the answer is false. Now, chapter 15. Hopefully, my internet doesn't go crazy. We have our objectives like we do normally, where there's terms. We've got to look at characteristics. We're going to describe the disease transmission. We have to compare and contrast some stuff. And y'all know we've got some images that we're going to look at. Okay. Now, one of the more difficult aspects of our field is witnessing the devastating effects of disease processes with our patients coming into the surgical environment of care. True story. I remember doing a case on a kid. Now, adults and children in itself can be a little bit daunting, but I had this patient coming in. We were doing a liver resection. He had metastasis, and didn't really think anything of it because we were helping him. Okay. A couple weeks later, I'm in the orthopedic service and I'm looking at this kid and I'm like, he looks so familiar. And this time, unfortunately, the cancer had spread to his bones and we were doing a arthroplasty for his, like, we were moving out his bone and we're giving him an implant. Okay. And I'm looking, and come to find out that was the same kid that we had that I was in general surgery a couple weeks earlier. And now, fast forward, here we are in ortho with the same kid. So sometimes these situations happen. Okay. Now, knowing that some of infections, not saying this one, but a lot of the infections are STDs or sexually transmitted, which are preventable with the use of protection, right? We look at pregnant females. They may have irreversible damage from pelvic inflammatory disease, PID, resulting in permanent damage in utero or during surgery. The thing about our field is we have to understand all of these complexities of different diseases that nobody intentionally becomes infected. Like, no one is sitting there going, you know what? I want a case of PID and a case of gonorrhea. No one's asking for that. And we have to realize that they may not even recognize that they have been infected. So, one thing that we have to do is kind of remove that sometimes unfair bias or perception. And then we find ourselves focusing our attention on taking care of our patients with that same dedication. Okay. And we're doing what we do for one patient for all patients. I mean, typically we're going to treat everybody like they got everything anyway, but we're going to give them that dignity and respect as we do it. So that was the significant topic for this week. Okay. Now, we talk about this particular group of bacteria. Okay. These are called protobacteria. They are gram negative, which means they do not hold a stain in the testing. So the stain will appear pink under a microscope. Okay. They're also aerobic, meaning that they have to have some type of oxygen to live. Like, they're not going to be in a non-oxygenated area. It's not going to benefit them. Most of these bacteria are spherical, but some are short and a bit oval shaped. One of the key features is that um, the bacteria is in the presence of endotoxins, which are harmful substances found in that outer layer of the bacterial cell membrane. Now, this layer is made up of something called lipopolysaccharides, LPS. These endotoxins can go in and they cause diseases by triggering the inflammation of the body. Now, the bacteria, they have special structures that help them kind of stick to tissue in the body, making it easier for them to cause infection. Two main types. We have meningitidis. The bacteria causes bacterial meningitis. This is that infection of the lining of the brain and spinal cord. And then we have none other than the gonorrhea. This bacteria causes gonorrhea, common STD, often referred to as the clap. Now, both of these bacteria have two important features that help them cause disease. And it's weird to say help them cause, right? They have what's called pili. Looking at the image, figure 15.1, the tiny hair-like structures on the surface of the bacteria, this is what allows them to stick to the tissues in the body. And this is why it's so hard for the immune system to remove them. When I look at this, I think of one of those alien movies when you have the little sticky things and they wrap around the body, the person, and it's hard for that individual to get out. Okay. And then there's the capsule, a protective layer around the bacteria that help them evade the body's immune system. Now, Neisseria gonorrhoeae is a gram-negative diplococcus, pairs of round-shaped bacteria. That's all that means, okay? They thrive in low oxygen environments and need extra carbon dioxide to grow. It's always considered a pathogen. And when we talk about pathogen, just think of disease causing. That's when we say, oh, that's pathogen. It causes disease. Gonorrhea usually affects the genitals, rectum, or the throat. Now, early in the infection, the bacteria stick to the mucus cells in these areas. Then they move into the deeper tissues, causing the infection to spread. Now, if it's not treated, gonorrhea can also spread through the bloodstream, causing secondary infections that may appear as skin rashes or even painful joint swelling. We know gonorrhea is an STD, and its symptoms can also include painful urination, abnormal discharge, or even sores. Now, if it is left untreated, it can lead to serious complications. Okay. The other thing to know is that it can sometimes remain unnoticed for months, silently killing and damaging reproductive organs. In females, we have a cervix. That is the typically the first place the bacteria infects. A major complication of untreated gonorrhea is PID, which is an infection of the reproductive organs in the abdomen. Females, of course, with PID, they're going to present with tenderness in the abdomen when touched or severe chronic pain along with abnormal vaginal discharge. PID can lead to other complications like salpingitis, inflammation of the fallopian tubes, which can cause a lot of scarring. We have oophorytis, and you're going to know as soon as you hear certain terms, you're going to know we're talking about the ovaries. When you hear salpingo or salpingitis, like this one, we're talking about the fallopian tube. So with oophorytis, inflammation of the ovaries, which can lead again to scarring and lead to infertility. One serious result of scarring from PID is an ectopic pregnancy. Now, this happens when a fertilized egg implants in the fallopian tube or anywhere else in the abdomen instead of the uterus. as that embryo grows, the fallopian tube is obviously going to rupture because it's not made to hold a growing embryo. Now, this is an emergency situation requiring surgery to stop bleeding and remove the embryo. Now, if a woman who is pregnant has gonorrhea, she can pass the infection to her baby during a vaginal delivery. Now, if the infection is diagnosed before labor begins, a C-section may be performed just to reduce the risk of the baby becoming infected. Okay. Now, in males, gonorrhea most often infects the urethra. That's the tube that carries urine from the bladder. After an incubation period of about 2 to 5 days, symptoms will start to appear. Okay. You'll have what's called urethral discharge, which is just pus like or abnormal fluid from the penis, and dysuria, just painful or difficult urination, can also occur. In some cases, gonorrhea can actually spread to the testicles, causing infection and scarring. This can lead to fertility issues because it's going to affect the organs involved in, of course, producing and transporting sperm. Another form of gonorrhea is gonococcal pharyngeal infection, pharyngitis, okay, which affects the throat. This can occur in anyone, of course, who engages in oral sex with a person who is infected. In some rare cases, though, gonorrhea can spread through the bloodstream, causing the disseminated infection. Now, when we talk about disseminated infections, we're talking about attacking joints, leading to serious life threatening effects. So we diagnose them, all right? They'll come in, they'll go see the doctor. They want to, of course, prevent long term damage. Doctors are going to do a urinalysis. We do a urinalysis usually always before any surgical procedure, especially with females that are childbearing age. Okay. But we're also trying to detect other things. So the doctor will go in and they'll do urinalysis to detect whether the patient has been infected with gonorrhea. They may also do a swab. In males, it's the urethra. We'll take the swab. Females, it's the cervix. And we can also do the throat and the rectum if need be. Now, the chapter talks about the NTT, the nucleic acid amplification test. It is the most reliable, and you may see this, it is the most reliable test for detecting gonorrhea and chlamydia. It has been approved by the FDA and is commonly used when we do those screenings. Okay. But hopefully there's antibiotics. Antibiotics is the primary treatment for gonorrhea. So we look at, unfortunately, gonorrhea has become resistant to several drugs. Penicillin, tetracycline, fluoroconazole, like ciprofloxacin. Okay, so this means that doctors have to be careful when choosing the right antibiotic for treatment. We look at ophthalmia neonatrium, love microbiology, great big words, where now we're talking about a gonococcal eye infection. And this is that what can be passed when babies are vaginally birthed with a mom who has active gonorrhea. Okay. So they can get it in their eyes. So we look at it as a serious condition, a serious problem. You have what's called corneal infections. We have ulcerations that can happen. There could be perforations, which is just a hole in the cornea caused by this disease passing to that newborn baby during delivery. But again, this can be prevented um, by applying erythromycin ophthalmic ointment to the baby's eyes right after birth. And all newborns, usually, regardless whether they are delivered vaginally or by C-section, they say, the chapter says, that should just receive this just to prevent any type of eye damage from going through the birth canal. Okay. We look at meningococcal meningitis. serious inflammation of your meninges. Your meninges are that protective layer around the brain and spinal cord. And this is caused by that bacteria, Neisseria meningitidis. The disease can develop very quickly and typically presents with classic signs: fever, headache. But then you may start to hear them talk about a stiff neck, nausea, vomiting, photophobia, which is they're opening their eyes and they're very sensitive to light. You may have them confused, or they may just be unresponsive due to the change in their mental state. As this disease worsens, the inflammation of the meninges increases. So then you start getting more pressure and pressure on the brain, leading to neurological problems. Fatalities can occur within hours of symptoms starting. Even if the person survives, there may be permanent brain damage or hearing loss. The chapter also talks about meningococcal septicemia. This is life-threatening disease, life-threatening infection, because now the disease is spreading into the bloodstream. Remember, your bloodstream is going all through your body. It causes damage to blood vessels and leads to bleeding in organs, skin, and even tissues. So this is how it happens. The bacteria enters the bloodstream through the nasopharynx, which is the throat area. And that's through endocarditis, which is a process where the bacteria are engulfed by the cells. Okay. Then the disease releases an endotoxin, which is just a harmful substance from the bacteria's outer membrane. That's going to damage blood vessels, and that's where you start to see vascular inflammation, blood clots, also known as thrombosis. You have DIC, which is disseminated intravascular coagulation, where clotting occurs all over the body. And think about it. If your blood is clotting all through your body, is it able to flow properly? Right? Now you have blood flow that's not normal, leading to severe bleeding and organ damage because the blood's not going where it needs to go and it's starting to bleed in different ways. Death can occur very quickly, either from meningitis, septicemia, or DIC, usually within hours. In cases where meningococcal septicemia does not lead to death, keep in mind it's still going to be severe. Treatment may involve amputation, fingers, toes, or other extremities that have been damaged by the infection. These patients are going to come into the operating room and we're going to do a debridement where we're removing that dead tissue. We may have the patient come back at another time for skin grafting just to cover the wounds. These are the cases you could potentially see. Now, symptoms of meningococcal septicemia include fatigue, general body aches, vomiting, diarrhea, chills. The patient may complain of feeling cold. They may have cold hands, cold feet, severe body pain. They might start breathing rapidly, have a really rapid heart rate, red pinpoint rashes, or they may even have dark purple rashes, which appear in the later stages of this particular infection. The chapter also talks about acute fulminating meningococcal septicemia, also known as Waterhouse-Friderichsen syndrome. This is a severe, rapidly progressing form of meningococcal septicemia that affects multiple organs in the body. It has a very high mortality rate, close to 100%, making it highly deadly infection. Okay, so 100%, that's pretty kind of big, right? Now, how do we diagnose these patients with meningococcal infections? Well, we can do it in 3 different ways. Meningococcal alone, just so you know, there's 30 to 50% cases. With septicemia, there's about 40% cases. And septicemia alone, 7 to of the cases. Now, we got to recognize what we got early, preferably, because it does become fatal, as you guys see, very quickly. And it's crucial because we want to prevent systematic shock and death. You do not want body organs, system organs to start shutting down. So there's a tubular test. It's a simple way to assess if a new rash might be a meningococcal, where we take a clear drinking glass, a tumbler, and press it against the rash. If the rash spots remain visible through the glass and do not fade or turn pale, it may be a sign of meningococcal infection, and you should seek immediate medical attention. This test is particularly helpful for parents of small children who may have trouble expressing that they have, chills and aches and different things. There's also the meningococcal PCR assay. It's a test, a rapid diagnostic method used to detect meningitis DNA, CSF. You've heard of that, where we go in and we take the cerebral spinal fluid, okay, just to confirm the infection, but that's the actual name. The most common treatment for meningococcal infections includes antibiotics. So you have penicillin G, you have third generation cephalosporins. All of these antibiotics, because of the nature of the disease, should be started immediately just to help prevent the infection from worsening. Again, we don't want the patient to go into systematic shock. We don't want death. Now, let's say they're in the hospital already. Okay, told you we got some images. As we get closer and closer to the end, there's going to be more imaging. Patients with meningococcal septicemia often require being in the hospital, getting extensive hospital care because of the severity of their infection, especially if it affects multiple organs. So, things that we think about: tissue care. If the infection leads to poor circulation, you see on A, that's necrotic, dead tissue, right? Gangrenous tissue. We're going to have to surgically debride it, meaning these patients are coming in to get that tissue removed. Sometimes it's necessary. Once that tissue is removed, the patient may come back for skin graft or, in some cases, amputation. Skin grafts may be synthetic material that we can cover large areas of lost skin until the patient recovers. Autologous grafting. Now, once the patient has passed the critical phase, okay, where now they're more stable, we can use the patient's own skin. And that can be performed to really just help the skin heal. And a lot of times they're going to be more compatible because you're taking skin from like their leg or their abdomen, their own skin, where there is going to be a better bond. But if the infection leads to severe tissue damage, especially in the extremities, you may have to do an amputation. However, this is going to be delayed until the patient is kind of stable and a clear line between healthy and dead tissue is visible. A lot of times we're bringing these patients back. You're going to have that team. They may be scheduled to come in every 3 days. And if you're scheduled, let's say you work Monday through Friday and you're on that team, you're going to see that patient twice. And then the weekend shift is going to see that patient. But they're going to try to keep it consistent. And what they're doing is trying to take off all of this tissue until we get to a point where we see fresh tissue. Sometimes we do what's called a fasciotomy, where we have compartment syndrome. And compartment syndrome is where pressure in a muscle compartment rises and then it threatens the flow. That's when we'll go in, orthopedics will do, they'll grab some long scissors and we go straight through and we create an opening in the fascia, fasciotomy, where we're cutting the muscle fascia to just kind of relieve that pressure. I want you to think of it like this. I want you to think of fasciotomy like you see someone, they have a pimple and they tell you not to bust it, right? But what happens when you have a huge ulcer or something and you see they take it through like a pimple, a pen, and then that pressure is released? Well, that's essentially what we're doing with a fasciotomy. Okay, just involves the fascia muscle. And we're relieving the pressure, helping to preserve circulation to the affected extremity or digits. And I see someone said transplant or auto. Could be either. We can do a transplant or auto. Great question. But we have to wait for these particular patients to be stable before we can even make that decision. But that is a great question. And sometimes, unfortunately, some patients are so autoimmune compromised that we cannot do auto. We have to do a transplant from a different, bovine or whatever. It just kind of depends on the patient's stability. But great question. We look at now we're moving from the necrocies to Moraxillus. Okay. These are still a protobacteria. Okay. They're gamma protobacterias. They're gram negative. They're non-motile, meaning they're not going to be moving. They're strictly aerobic. So they have a shape between a cocci and a rod, kind of in between. These are well-known, previously named Micrococcus catarrhalis. Love the words. But these are going to be like the third most common cause of otitis media. Okay, so that's why you see the pictures of the ears up here. Okay, and I'm talking about middle ear infections, especially in children following streptococcus pneumonia. So if a patient, usually these little babies, kids, they've had pneumonia and now they may complain of ear aches or the babies will be grabbing at their ears. Okay. Also, from influenza, it causes around 3 to 4 million cases annually in the United States. It's also involved in adults that have like a lot of sinusitis, bronchitis, bronchopneumonia, especially in our older adults who have conditions like COPD, which is just chronic obstructive pulmonary disease. Okay. So we look at spirochetes. Okay. These come from Greek spira, and that's why you get spiral, and chate, which means mane, describing their spiral shape. These can either be facultative anaerobes or aerobes. Now, these cause treponemia, causing syphilis, Lyme disease, leprosy or leptospira, syphilis. Let's see what else. They have, as you can see, snake-like. They have tight coils. And this is what you see under a microscope. So with a naked eye, you're not going to be like, haha, I know what that is. It's going to be under a microscope. But they do kind of resemble corkscrews, or if those of us tell my age that had the telephone cord, the phone that was in the kitchen, everybody could grab it. It's the long telephone cord. Kind of looks like that as well. Okay. Now, due to their extreme thinness, um, they may require a dark field or electron microscopy just to have clear visualization, just food for thought. Okay. Just so you guys know. Now, we get into Treponema species. They're part of the normal flora. So I guys want you to know that they're part of the normal microflora of your oropharynx, but are delicate organisms. Okay. So they have growth requirements. You may see these questions, you may not. They have a pH of 7.2 to 7.4. It's right on the screen. Temperature 30 degrees Celsius to 37 degrees Celsius. Require low oxygen levels. They have high lipid content, making them more resistant to environmental changes. Some of the diseases: venereal syphilis, um, endemic syphilis, and non-venereal syphilis. These diseases are collectively known as treponematices because they follow distinct stages in progression. Okay. So we have your primary stage. You have the Charance formation that moves into rashes and lesions, and then your latent stage that has no symptoms. And then we get into the territory stage where now you go from no symptoms to organ damage. Okay. Now, a slow evolving disease with periods of rapid bacterial multiplication, followed by asymptomatic stages. That's what you think of it when you look at it. It's like progress, stagnant, everything shuts down. Okay, so that's kind of the stages and a breakdown. Transmission is primarily through sexual contact, but also through blood transfusions, infected hypodermic needles, breast milk, saliva. They can survive on surfaces for only about 2 hours. Um, so you have your first stages. The primary and secondary stages of syphilis are curable with penicillin injection or a course of tetracycline. Biggest thing is early detection. That's with everything, okay? Because you want to prevent the transmission, especially to an unborn fetus during pregnancy. Syphilis requires a moist, dark environment, making it well suited for transmission through sexual contact. A couple more images. So you get your primary stage 10 to 60 days after exposure. Small, hard, ulcerous lesion. That's what the chancery is. If anyone was wondering when I said chancery, that's what that is. Okay, just a small, hard, ulcerous lesion appears at the site of bacterial entry. Typically, a single lesion, but in HIV/AIDS patients, there's going to be multiple lesions may develop. The chancery can appear on sexual organs, anus, or in this case, you guys can see the mouth. The lesion contains highly infectious fluids. And this stage is when syphilis is the most contagious. Your secondary stage occurs 1 week to 6 months after the chancery heals. Now, the bacteria spread to other tissues, including the CNS, which is the central nervous system, which unfortunately is often affected. You're going to have a widespread rash, appears typically concentrated on soles of the feet, palms of the hand, genitals. You may even have lesions in mucous membranes where where they can actually secrete infectious fluids. The secondary stage can last 3 to 6 months and is marked by infectious lesions that contribute through transmission. Now, these two stages just highlight the progression of syphilis, okay? In the latent stage, this occurs between the primary and secondary stages. Again, there's no obvious visible symptoms, okay? The host may not even be infectious during this period, may not be infectious, all right? Pregnant women can pass the infection to their unborn child, leading to congenital syphilis. The infected individual may experience vague discomfort, but no clear signs of a disease are present. Approximately 50 to 70% of individuals in this stage do not progress to the final tertiary stage or the late stage. Now, the late stage occurs 10 to 30 years after the initial infection. I'll repeat that. 10 to 30 years after the initial infection. So you're going to have serious damage to the invaded tissues. You may have soft tumor-like growths, okay? The disease can affect any organ or tissue in the body, leading to various manifestations. You can have neurosyphilis, where it's affecting the nervous system, causing neurological, cardiovascular syphilis, where it's affecting the heart. You have syphilitic aortitis, causing inflammation in the aorta, potentially leading to aneurysms and ruptures. The latent stage represents the most severe stage of syphilis, and if left untreated, it can result in significant organ damage, disability, or unfortunate death. Now, we look at breaking down neurosyphilis just a little bit more because we're talking about affecting the spinal cord. So some of the symptoms, keep in mind, 10 to 30 years, right? We're looking at numbness in the extremities due to sensory nerve damage. You may have tab dorsalis, which is a condition marked by progressive degeneration of the spinal cord, leading to like a characteristic gait. It's wide base. They have an unsteady, you see them kind of like walking like that, and they may have deformed knees. They're going to have gait issues because of the nerve damage. It impairs coordination, causing a lack of muscle control, and then it leads to difficulty walking. You have skeletal system being involved as well. Bony destructions leading to destruction of bone tissue. Your bones are going to become weak. So they're going to be experiencing frequent fractures with a tap, minimal trauma. They may have facial disfigurement, nasal pharyngeal damage, the bones around the palate, leading to significant. There may be damage to your saddle nose deformity where the bridge actually of the nose just collapse. And there may even be other facial deformities. And I couldn't find images that weren't too crazy. So I'll try to look those up. We also have what's called yaws. Okay. Unlike syphilis, yaws is not sexually transmitted and typically affects children in tropical regions. In hyperendemic areas, up to 75% of the population may be infected by the age 20. Most causes occur in children age 5 to 15 years, often in rural or underdeveloped regions. So there are clinical stages of yaws. You have your primary stage, begins with the appearance of painless red papules known as the mother yaw, where the bacteria kind of enters the body, often through broken skin or mucous membranes. The lesion resembles a raspberry-like papule. So you'll have scratching of the lesions is a way to kind of spread it, especially among children who often have poor hygiene. Your secondary stage after a period of latency, similar to syphilis, the disease progresses to form internal and external lesions. Okay. Now keep in mind, thinking about where the area is. These lesions are going to go, they're going to affect the skin, they're going to affect the bones and other tissues. The infection may spread to multiple areas, causing further destruction. There are long term effects. If left untreated, yaws can cause skin, bone, and tissue damage, similar to late stage of syphilis. Chronic stages of yaws is going to lead to disfigurement and complications like bone deformities. Quick question before we get too far, going back. Could this be hereditary 30 years back if the mother was born before her 30s? Are we talking about syphilis? We're talking about yaws
We're going back to the infant was born with the left lesion on her hands.
for okay, how far back are we going?
Back two slides
Okay, hold
back.
on.
This
A
one right
newborn
here.
infant with copper colored rash could be definitely passed through yeah, passed through hereditary.
Okay,
Congenital. That's the word, congenital. Congenital.
gotcha. Okay.
I was like, going through congenital. Great question. All right. So, keep in mind what you see figures 15, 19. Um, this is yaws. Okay. We have Borrelia. Now, this is a helical shaped bacteria with 3 to 10 loose coils, and about 15 to 20 axil filaments. They are thicker, less curved compared to Treponema. Okay. I want you to think of vectors like lice. All right. Um, ticks. So you can kind of see the vectors and how the host can get infected with these particular diseases. Okay. Other things to think of: Lyme disease. All right. When we talk about Lyme disease specifically, they are very highly motile, meaning they're moving. Okay. They have they move easily through body fluids and tissue. They have a slime layer. Okay. That's how they're able to kind of get in where they, I guess, fit in. Um, the bacterium invades healthy human cells, causing the cell's own digestive enzymes to break down the cell. And as it exits, it coats itself with a portion of the cell wall, helping it avoid the immune detection because it's kind of like a facade, like it mimics the host's immune system because it's grabbed some of it and that's how it's able to kind of do its thing. Okay. With Leptospira, now these are thin, flexible, tightly coiled, gram negative bacteria, making them highly motile. These bacteria do require oxygen to survive and live. They have a helical shape, but they are distinguished by their hooked ends, which are characteristic of the Leptospira genus. That's kind of why I grabbed that particular image. They typically go, they're typically in the urine of infected animals. Okay. Commonly transmitted via infected animal urine, especially from dogs, domestic livestock like our cattle, our swine, our horses, and our rodents. The bacteria are often present in the renal tubules of these animals, and then that's how they go through the urine. Um, we have certain stages, okay? Sudden onset begins abruptly with a high fever, severe headache. We have some patients complain of eye pain or again that photophobia where light they become sensitive to it. And in some cases, there is a hemorrhagic rash. Now, after a brief asystematic period, usually about 1 to 3 days, the bacteria are cleared from the bloodstream, and then the body starts to develop an inflammatory response. Okay, so that's actually pretty good. There's also Wales disease, Weil, not Whale. Okay, where you have severe jaundice. You may have hemorrhagic features like bleeding and what they call black vomit. If untreated, Wells disease can be fatal due to liver failure or renal failure. Now, it was named after A. Weil, who was a German physician who identified the disease back in 1886. Okay, so how do we treat it? Doxycycline, penicillin. These are going to be the most effective if administered early. With everything, you want to catch these things early. Okay. All right. Looking at the time, we are going to skip our group activity just because I want you guys to be able to get a break before we come back. And we're going to get into our last two questions from our mini session. Okay. With every question, if you guys have noticed, I'm going to give you rationales as well. Which of the following statements about Campylobacter jejuni is correct? A, it's highly resistant to environmental changes and can survive in dry, acidic, or high oxygenated conditions. Or B, it is a leading cause of diarrheal illness in the United States and can be transmitted to humans through contaminated poultry or pasteurized milk. And right off the bat, The answer is B. Good job. All right, our next question. Good job, everybody. True or false? Providicida sturtai is commonly found in animals such as cats, dogs, birds, sheep, and reptiles, where it typically causes severe infections in humans. I did this twice. Aha, you guys got it. So I grabbed it twice, okay, just to see, did it in the beginning and then again to catch it, and you guys got it. Usually lives harmlessly in those hosts. Good job, everybody. Good job. All right. For those of you that are watching this playback, I have some questions for you, three to be exact. How can the unique characteristics of Leptospira contribute to its ability to evade the host immune system during the infection process? In what ways could early detection and treatment of Lyme disease prevent long term complications such as post treatment Lyme disease syndrome? And given that Treponema pallidum can cause a long term tissue damage if untreated, how might early intervention in syphilis affect both individual health and public health outcomes? Let's talk about it in the discussion forum. Quote of the week: your present circumstances do not determine where you can go, they merely determine where you start. All right, y'all. I want you guys to take a nice, good break, grab a drink of water, and I will look forward to everyone who can attend the ST200 in the 200 link at 6:10. See you guys in a little bit.